Thank you. It gives me great pleasure to introduce to you our two speakers, Doctors Todd and Jen Winton from Active Lifestyle Clinic, who run a busy clinic that integrates naturopathic medicine, chiropractic care, and physical therapy. Dr. Todd Winton received his pre-med courses at Arizona State University and graduated from Southwest College of Naturopathic Medicine in 1999. So he's one of our earlier grads. For over 19 years, Dr. Todd Winton has used bioidentical hormones, regenerative joint injections, ozone treatments, and lifestyle coaching to help patients achieve their health goals. Dr. Jen Winton has been practicing with Dr. Todd for the past 9 years, but has practiced chiropractic for over 16 years. Dr. Jen enjoys working with patients of all ages, from newborns to seniors. She received her BA from the University of Washington in Seattle, and then she graduated from Palmer College of Chiropractic West in 2003 with her doctorate in chiropractic. Together, both doctors successfully co-treat patients for pain management in their Ahwatukee practice. While Dr. Jen focuses on joint restrictions and nerve impingement with spinal adjustments, Dr. Todd treats hypermobility and degeneration with regenerative joint injections. They also work with an experienced physical therapist to address muscular imbalances. The three practitioners have found a symbiotic working relationship that benefits both the patient and the practice. Let's give a nice warm welcome to Drs. Todd and Jen Winton.
So I'm Dr. Winton. In our practice, I go by Dr. Todd, I go by Dr. Jen. Everybody's like, why don't you use your last name? It's just really confusing. I always say Dr. Winton. So we gave you a handout of the MDNR write-up that we did about 3 years ago. Just kind of talking about the PI patients and treating them. It's kind of goes into that detail. If you guys are interested at all with physical medicine, then adding PI to your practice is very helpful. In fact, Dr. Nick still teaches here, right?
He just retired.
What?
Just retired.
Wow.
This quarter.
Yeah, so he's like the oldest teacher when they. So, anyways, I remember him teaching like a couple of classes on how to do a PI, how to work with a PI patient. And I would say that was one of the most important classes I ever took. I didn't realize it. Right? That's a lot of times what you'll find out is later on. It's like, oh, I should have focused on that a little bit more. But
I'm going to talk about PI because you guys know what PI means?
oh, posterior inferior. Whoa.
Yes. I'm so proud of you guys. Personal injury, automatic.
Yeah.
But we will. I'm going to be talking about that. I'm so proud of you guys for that.
That's awesome.
You can have PI from PI.
Yeah.
Thank you for clarifying.
I'm just here to help.
So first we want to talk about finding our niche, and as you heard Ms. Hagan say, there's several things that I have done. I started off. Actually, what I enjoyed the most once I graduated from school was acupuncture, homeopathy, and hydrotherapy, of which now I do 0. And reflecting back, I go, what was it? Why was I so excited about those courses? And I would say because I had teachers that were really passionate about those subjects. And, passion is just, it's contagious. And I became excited about it too. but you know, once I got in practice, and I figured out it's like, you know, that just wasn't what really resonated with me and what I wanted to do with my practice, and what was what I found that I can help people with most. So I kind of liken it to my being a younger brother and just wanted to be like my brother growing up. And so again, it's just important to find what your focus is and what you love. And then, so that's one part of the niche, right? It's trying to figure out what treatments do I enjoy, what I want to work with. The other thing is what type of patients do you want to see? And so, of course, in our practice, a lot of our patients are musculoskeletal, right? So, and that's a big part of our focus. But you know, as a naturopath, I've seen a lot. I've seen cancer patients to kidney failure, hormones. I mean, I've seen the whole gamut of different patients. And so then the goal is, well, what can I really help people with? And what are my limitations? And so, again, that's why it's good to have a niche. So, and focus. So even though I do help a lot of people, especially with weight loss and hormones, but what our focus and niche is musculoskeletal issues. So one way I use that is I have other naturopaths that I refer to, which I'm like, okay, I'm over my head with hormones here. I don't know what to do. I might be able to help 80% of the patients that walk in to some degree, but then there's some that I can't help. And then it's good for you to have those people that you go, oh, you're the one to go to. For example, for diabetes, I refer to Morstein, Dr. Morstein. So, you know, Dr. Morstein is just known for blood sugar issues, right? So she's on my list. So I have this whole list of people I refer to, and which have their niches that they love. My wife told me when I do this talk, I should have transitions, which I'm horrible with transitions. Just hit the delete button on my phone. Okay. So that's the niches, and then the next thing we're going to talk about.
Yeah. So, hey everybody. You guys smells good in here. Haven't had lunch yet. So, I'm a chiropractor, as I was introduced, and when I first got out of school, well, actually when I was in school, I don't know if they say this to you, but they told us chiropractors, be careful for those naturopaths, because they're going to want to do the manipulations. And then they say, be careful for those physical therapists, because they're going to want to do the manipulations, you know, because that's all we do, really. And they scared us all. And so when I met Dr. Todd, we got married, and he jumped in, and I already had a chiropractic practice, and he joined my practice. And I was kind of hesitant about him working in the pain area, so pain realm. So I focused on the adjustments, the restriction, and he was mainly focusing on hormones, but Dr. Todd started out, like he said, with this much, and this is what I tell patients. You guys, we do a field observation within our clinic, so Corbin's been to our clinic. Anybody else in here been to our clinic? Not yet. Oh, Brittany has, so she's going to do some more volunteer and shadowing. But what I try to impart on the students that come into our clinic is, finding a niche, right, and working with other like-minded providers. Because what they told us in school about being afraid of other providers that might take our area of expertise is really just a lie. It's really false. And actually, when you work with other providers, it really enhances your care. It gets the patient better faster, and, well, everybody wins because, the patient's paying too. So everybody is winning in the end. So that's what's happened, and then what happened was I got pregnant. Yes. And They say chiropractors have the worst back pain when they're pregnant, and it's really true because I'm over people like this all day long with my knee doing this, and I'm hunched over and doing these things. And so my belly brought my weight forward so much that I had excruciating sacroiliac joint pain. And I went to two chiropractic specialists that specialize in pregnancy, and they both made me way worse. I mean, my pain was like an 8 or 9 out of 10, and I don't even use the number 10, but it was so bad that I was in tears. Like, I had never had back pain before. And my staff was wheeling me around in one of these wheelchairs because I couldn't even walk, and I had to put on a fake smile for my patients. It was pretty bad. So I went to those chiropractors and they made me worse. So I tried yoga and it made me worse. And our physical therapist, who happens to be my best friend, went to her, worse. And stretching, worse. So everything I did, massage, it was not working and making me worse. So I was like a 9 in tears. And Dr. Todd took some courses in prolotherapy. Of course, I was his guinea pig, but I can't even tell you, I am the biggest fan. If I wasn't already married to a naturopath, I would be here in class with you guys because I am such a big, firm believer in what prolotherapy did for me. So it took my pain down to a 0. I was able to get all the way through my pregnancy and my second one, pain-free because of prolotherapy, so it really opened my eyes. And I had already been practicing for, 13 years prior to meeting you. And I was kind of protective of the pain area in focus in our clinic. And when he wanted to get like, hey, I'm going to do prolotherapy, I'm going to do prolozone, has anybody learned those modalities yet? Okay, Dr. Todd's going to talk about it at the end, so it might be very interesting to you because we want to introduce all the kinds of regenerative and joint injections that we do, that he does. So, because I was such a believer, I started telling all my patients, and he started practicing prolotherapy like crazy, and soon his business was like just jam-packed. And it's this relationship that we had back and forth. He was sending me patients, I was sending him patients, and because he was working with me with the prolotherapy, let me take a step back. So as a chiropractor, our main focus is the hypomobility, so the restricted stuffed joint, right? When a joint is too loose, the ligaments between the bones are just loosey-goosey. I kind of talk to patients, so I'm not doing technical work with you guys, but the ligaments are hypermobile, stretched out, and there is nothing I can do about that. I can adjust the other side or around it. You can't strengthen a ligament because there's no blood supply, as you know. So there's really, these people are just hurting, just like I was when I was pregnant. If you sprain an ankle, you injure a rotator cuff, it's going to cause a hypermobility. If you fall, you can get hypermobile ligaments in your wrist, your shoulder, and your spine. And so it opened my eyes about co-treating for pain. And ever since then, we've had a really wonderful relationship with our patients, going back and forth between the two of us. Oftentimes patients come in to see me and I'm like, oh, this is really loose and popping and clicking in here. You're in the wrong place. You need to make an appointment with Dr. Todd right away. And he has the same thing. Oh, you came in for, you know, I see you have hormones, but you're telling me about your back pain. You need to see Dr. Jen. So it's really just boosted both of our practices up to the next level. And I can't stress enough how complementary it's been.
And then what would normally happen with the hypermobile patient in the chiropractic?
Yeah, and every chiropractor I know, they kind of have an ego like everything's a chiropractic adjustment, but they can't help them. And if they keep adjusting it, which is what I see all the time, they come in and they're like, oh, my chiropractor's adjusted. I have a patient right now, I can tell you about her. She came in, I keep getting adjusted and adjusted and adjusted, and it's not helping. So I said, okay, what we're gonna do is we're gonna put it in place with an adjustment. You're gonna get prolotherapy with Dr. Todd, and we're gonna leave it alone. And she feels amazing. She was just being over-adjusted, and was probably hypermobile to begin with. So either they're gonna get worse or they're not gonna get the care they need. Thank you for having me talk. So, let's see. Another example I wanted to talk about co-treating was where it went wrong, actually, is when Dr. Todd and I first started working together, he had been approached by another chiropractor to come work in my clinic 2 days a week. So he went over there, and this is why it doesn't work. Because each provider, if you're gonna work with other naturopaths, you're gonna work with chiropractors, or you're gonna work with, medical doctors or whoever, whatever provider, you have to realize what you're good at and what they're good at. Maybe you can do the things that they do, but if your specialty is specifically, like mine is chiropractic, I shouldn't, and I can do vitamins, I can work on people with digestive issues, I can work on hormones, and that's what this chiropractor did, is he did it all. He did nutritional medicine with vitamins, but he wasn't doing any lab work. He wasn't as thorough as he could have been, okay? And he was just throwing vitamins here and there, and maybe some people get better. I've done that before I met Dr. Todd, and some people got better. But for the most part, I would just lose the patient, they wouldn't come back, because they weren't getting any results. And so this doctor had a naturopath in his office that was doing blood work and could be thorough, he could prescribe, which we can't do, and he wasn't taking advantage of it, so that didn't work. So the key to success of referring back and forth is knowing what your strengths are as a provider and as an individual doctor. And maybe even if you're a naturopath and you want to specialize in hormones, for example, but Dr. Todd doesn't specialize, he doesn't work with children. So we have another naturopath we refer to that does pediatric naturopathic medicine. And that works out really great. So that's another example. So what I wanted to suggest to you students is start thinking now. I don't know if you're early in your learning or if you're later in your quarters, but start thinking now of a niche, like Dr. Todd mentioned. You may have certain areas that you like, right? You might be gravitated towards homeopathy, or might be gravitate towards, like Corbin's interested in learning manual manipulations. Find out what you might like, and it might be this big. I mean, you're going to learn this much in school, and then you want to go, okay, this is what I'm interested in. And then as you get closer to graduating, you're going to say, okay, I like these 5 to 10 things or whatever, let's say, okay? And whatever that area is, start thinking about other providers that are complementary to that see that patient, okay? So for me as a chiropractor, I want a naturopath on my team, I want a physical therapist on my team, I want counselors, because a lot of pain is, anxiety and depression and all that. I mean, a lot of it is. So you want counselors on your list if you're working with pain, or pretty much anything. We have neurologists on our list. We have some medical doctors. They're hard to work with for many reasons. And you want orthopedics to refer to. You won't get them back, but you'll send them there. Maybe attorneys, like we work with the PI, the personal injury cases. So we have lots of attorneys that we like, and there's some good ones and bad ones out there with everything. Podiatrists. So you think about like who sees your patient. And then what I would recommend is when you get out of school, no matter what you do, if you're working for somebody or working on your own, or you start your own business, or you do a preceptorship, what do they call it when you get out and you work for somebody? Residency. Thank you. If you do a residency, so start thinking about who sees your patient, and start making a list of the kinds of providers you want to meet. And then I would suggest going out and meeting them. So get some good cards made when you graduate, and then go out and say, hey, I'm Dr. So-and-so, my practice is down the street, just wanted to shake hands with you so you know what I do, okay? And then if they see you enough, or they hear about you, or you start sending patients to them, they'll be like, oh yeah, that doctor, let me send some back. And then you start having a relationship. If you can get 2 or 3 medical doctors sending patients to you, you guys are golden. It's hard to do with the medical doctors, but in Dr. Todd's example, he has a chiropractor sending him patients all the time. That's golden, And I have a naturopath sending me patients all the time. And then our physical therapist, just to mention her, she wanted to be here today, but she couldn't. She does the muscle and soft tissue aspect of pain, and I do the bone and nerve aspect of pain. Now, can I do physical therapy? I was trained in it. I took boards, I passed in physical therapy, because that's part of our boards. But why would I do that when she does it so much better? Can she do manipulation? She can. She can adjust joints. Well, why would she when I'm really good at it, right? So we just want to find people that see our patients and start forming those relationships. Another thing that you can do that I've learned, because I've done several years of coaching, chiropractic coaching, management companies, spent a lot of money. So I'm trying to impart some of my wisdom to you guys, and we always do that with our field observation students, is start, what was I going to say? I forgot my thought. Physical therapy. Oh, I'll come back to it. It's gone. I worked since 7 this morning, so.
You said you were
What was I saying?
coaching.
What was I saying?
Coaching and.
Coaching, yes.
Teaching.
Thank you. It's really close.
What to tell all the students.
I have so
Trying
much.
to impart it on people.
Yeah, we'll come back to it. But thank you. You're really, really close. So, like Dr. Todd mentioned, you may have certain areas that you like, right? You might be gravitated towards homeopathy, or might be gravitate towards, like Corbin's interested in learning manual manipulations. Find out what you might like, and it might be this big. I mean, you're going to learn this much in school, and then you want to go, okay, this is what I'm interested in. And then as you get closer to graduating, you're going to say, okay, I like these 5 to 10 things, or whatever, let's say, okay? And whatever that area is, start thinking about other providers that are complementary to that see that patient, okay? So for me as a chiropractor, I want a naturopath on my team, I want a physical therapist on my team, I want counselors, because a lot of pain is, you know, anxiety and depression and all that. I mean, a lot of it is. So you want counselors on your list if you're working with pain, or pretty much anything. We have neurologists on our list. We have some medical doctors. They're hard to work with for many reasons. You want orthopedics to refer to. You won't get them back, but you'll send them there. Maybe attorneys, like we work with the PI, the personal injury cases, so we have lots of attorneys that we like, and there's some good ones and bad ones out there with everything. Podiatrists, so you think about like who sees your patient, and then what I would recommend is when you get out of school, no matter what you do, if you're working for somebody or working on your own, or you start your own business, or you do a preceptorship, what do they call it when you get out and you work for somebody? Thank you. If you do a residency, so start thinking about who sees your patient, and start making a list of the kinds of providers you want to meet. And then I would suggest going out and meeting them. So get some good cards made when you graduate, and then go out and say, hey, I'm Dr. So-and-so, my practice is down the street, just wanted to shake hands with you so you know what I do, okay? And then if they see you enough, or they hear about you, or you start sending patients to them, they'll be like, oh yeah, that doctor, let me send some back. And then you start having a relationship. If you can get 2 or 3 medical doctors sending patients to you, you guys are golden. It's hard to do with medical doctors, but in Dr. Todd's example, he has a chiropractor sending him patients all the time. That's golden, you know? And I have a naturopath sending me patients all the time. And then our physical therapist, just to mention her, she wanted to be here today, but she couldn't. She does the muscle and soft tissue aspect of pain, and I do the bone and nerve aspect of pain. Now, can I do physical therapy? I was trained in it. I took boards, I passed in physical therapy, because that's a part of our boards. But why would I do that when she does it so much better? Can she do manipulation? She can. She can adjust joints. But why would she when I'm really good at it, right? So we just want to find people that see our patients and start forming those relationships. Another thing that you can do that I've learned, because I've done several years of coaching, chiropractic coaching, management companies, spent a lot of money, so I'm trying to impart some of my wisdom to you guys, and we always do that with our field observation students, is start, what was I going to say? I forgot my thought. Physical therapy. Oh, I'll come back to it. It's gone. I worked since 7 this morning, so.
You said you were
What was I saying?
coaching.
What was I saying?
Coaching and.
Coaching, yes. What's the coaching?
Like teaching.
Thank you. It's really close.
What to tell all the students.
I have so
Trying
much.
to impart it on people.
Yeah. I'll come back to it. It's gone. But thank you. You're really, really close. So anyway, now, so you make a list and you want to go, oh, yeah, it's back. So one of my coaching companies had taught me this little trick that I wanted to share with you guys. And what you can do is, if you have a new patient, hopefully you can get an electronic medical record software when you get out, because it makes it easier. But
you just type up your notes or put them in the software, and if you can get a report or some sort of form that you fill out, like what you saw and what your objective findings were, and then fax it over to their primary care doctor that they see, they'll start seeing more and more of your name, okay? They're like, oh, this doctor keeps bothering me. Who is this person? And then they'll eventually see like, oh, they're getting my patients better. Okay, and that's a really good way to start building relationships. And then if you can get them to lunch, it's best. So Dr. Todd and I try to take out, we try to go out to lunch once a month, that's our goal, with another provider. It could be anybody, it could be an attorney, it could be a physical therapist, it could be, another naturopath, and we just try to meet people. We don't always get to do it, but that's our goal, is once a month. Sometimes we pay, sometimes they pay, whatever. But it's nice to get out there and meet them, and then you're one-on-one. And you're gonna meet people and discuss, like, this is what I do, and they'll either gravitate towards your personality or they won't. So yeah, that's another good idea. So start building that referral network now. And then I want to just talk briefly before I bring Dr. Todd back up to talk about all the types of injections, about co-treating specifically with a personal injury, the PI. I'm just going to see PI. Well, before I met Dr. Todd, I was treating PI cases all by myself. People would come in, they get in a car accident, I do chiropractic care. It could take 12 to 20 weeks, and I start them out 3 times a week, and then I go to 2, and then I go to 1. And then Dr. Todd came on. It looks much better if you can work with other providers, because it kind of validates your findings. If you have another doctor say, yeah, this is true, this is what I'm finding, these are my objective findings, okay? So when I do my chiropractic care for PI, Dr. Todd does trigger point injections. He also can offer medications, so sometimes people need a muscle relaxer or anti-inflammatory or soma or whatever he deems appropriate. And that can really take the edge off. I'm not a big fan of medications. You guys probably aren't either, but sometimes it's necessary when they're, really in a lot of pain. And it's great that you guys can prescribe. So a prescription is sometimes necessary, and then the trigger point injections. Dr. Todd does other injections as well for the PI, so he can get into that in a minute. That's his area of expertise. And then our physical therapist is also in on the PI. So they really get everything in one office, and people really like that. They like coming and saying, I'm getting everything in one place, and they don't have to go get referred here and referred there. So, and they get better quicker, which is nice. So typically your PIs run between $2,000 and $4,000 or $5,000 per person. We don't overtreat, but then that's just his bill, and then there's mine, and then there's PI or physical therapy. So it's lucrative. PI is really lucrative. I just gave you guys that article because it goes into specifics of how we do it in our office, but chiropractors are pretty good about doing car accidents, but we would really like to see more naturopaths getting in on this. You guys can help them more than the medical doctors. Because the medical doctors can typically just give them a medication and anything. They really typically don't get surgery unless it's a really bad case. They shouldn't be in our office and getting surgery. But it's kind of a gold mine and something to look at if you're interested in practicing in the pain area. So what I want to tell you about that. Typically, just some details is when I see a patient 3 times a week when they come in, that's kind of what I'll do when they're in a lot of pain, is see them 3 times a week. And then Dr. Todd will see them 2 times a week when I see them. And then once I take them down to 2 times a week, they're feeling better. Their pain is like 50% decreased or less. And then he takes them down to 1 time a week. And then when I'm down to 1 time a week, he's pretty much done. Unless he's stabilizing a joint with prolotherapy, that can happen. And then the physical therapist tails it off and finishes the case after I'm done, because she's doing the rehab part and the exercises and the strengthening. She really focuses on myofascial release and functional movement. So, and what else do I want to tell you about the PIs? But yeah, I really encourage you guys to look at that if you're interested in treating the pain patients. So my point is, just one sec, is that when you work together, not only does the patient get better, but it's just lucrative and it makes your practice busier and more successful. And that's what we want for you guys. And we're always here to support the profession. So, you have any questions?
So is that a plan that you guys had discussed, I guess, as you had Dr. Todd come on board and the physical therapist come on board? You kind of created, this is how we're going to see them as a team.
Yeah, that's a good question. Sometimes I take the lead on the case, and if I do, I'll just put them right on my 3 times a week protocol, because that's kind of how it's standard in the chiropractic profession, unless you're not in pain, and then we just jump down to 2 or 1. Dr. Todd has found, and he can talk about this, but it works really well when a patient is acute to do the 2 times a week. And so it just kind of coincided, it just worked really well. And then the physical therapist, we're looking for a second one, because she's at like over 100%. I know that's not a real number, but works more out of her scheduled hours than she can, because she's, yeah, you have to book 3 weeks out for her, because she's that busy. And she's cash only, you guys. Cash only. Let me just take a second and tell you about that, and I'll kind of try to answer your question in that. Christine has worked in physical therapy for the same amount of time as I was practicing, for 17 years. And she just got so frustrated because in physical therapy, if any of you guys have gone to a physical therapist, you get an evaluation from the PT, and then typically, not always, but typically, the PT, the aides, or the techs are going to take you through your exercises each time, right? And the PT, what are they doing? They're just taking notes the whole time. It's so frustrating because they don't get their hands on you, okay? And so she's so frustrated. She's just like, I love physical therapy, but I can't handle the paperwork anymore.
And she can't treat the whole person either.
Yeah, you can't treat the whole person because you're referred from a medical doctor, or one of us, a naturopath or chiro, and they can only treat the low back because that's the diagnosis, right? So she came to our office, and we thought, well, let's just start with 4 hours a week and let's see if we can fill you up. Well, like within 2 weeks, she was working full max and totally booked out, because I was referring everybody to her, because sometimes I can't adjust somebody. Sometimes you guys are like, patients are just too tight. I say you guys because, well, if you're a patient, or patients are just too tight. And so I'm like, well, you need to get in with a physical therapist, loosen up these muscles so I can get in, and then it's like butter. It's just everything moves so smooth, and then the nerves aren't pinched anymore. It's a beautiful thing. So her typical protocols were already kind of like once or twice a week, because patients are paying cash. And it's kind of expensive to do 3 times a week, and she doesn't have the time in her schedule, so it just kind of worked out that way, that she treats once, twice a week, he treats twice, and I treat 3 for acute patients. And then it all worked to where we were just cohesive together. Good question. So any other questions for me? I'm going to bring Dr. Todd back up. Yeah.
Is that sometimes, or just on a case-by-case basis then?
Yes, of course. Yeah, we don't put anybody in a box. Everybody's unique. So I have patients that come in all the time that start at once a month because they're already feeling good. And Dr. Todd, I mean, it totally varies. In fact, he likes paper notes so much because electronic notes is too much in a box for all the kinds of patients that he sees. So I don't know what they look like for you guys here in the clinic, but I hear they're cumbersome, but you'll have to go out and see what kind of electronic medical records are out when you graduate. And I love it. It's easy, it's fast. Once you do the initial note and it's quick, then it's kind of, you copy the previous note and then make any changes. Put your subjectives and objectives if they change. So it's really fast. Like my notes take like 2 minutes. So, yeah. But
I do the electronic notes whenever I do the PI classes, PI cases. And that's because it's going to an insurance company and lawyers and everything like that. So I just put a few things in, and then when you push the print button, it's like 2 pages pop out. It's like, that looks good.
Or 4.
It's like I really know what I'm talking about here. So continuing with the personal injury patients. So usually when they first come in, so it was just an accident, usually the first treatment I do is called neuroprolotherapy, or it's just a 5% dextrose solution. So I'm just going to kind of go through the different types of injections that I do. And this is really one of the most basic things I do. It's 5% dextrose. It still blows me away. I do these injections on people. I follow the nerve lines, and it either works or it doesn't. And it's almost immediate. It's crazy. It's like magic. And so I'll have the person, they'll do the range of motion. It's like, oh yeah, it hurts right there, and I'll do my little shots in there. And if it helps, like within 10, 15 seconds, they're like, oh yeah, I feel a lot better. That was amazing. And it, I don't even like to tell them what's in it. I'm embarrassed. But I do have this one patient who's had radiation, and you see there's radiation scars all around his neck, and for thyroid cancer, and he just loves it. He eats it up. I'll do the neural prolo around his neck and throughout his shoulders, and he'll talk about, oh, I can feel my finger again. Oh, the numbness is going away as I'm doing the shots. So anyways, if you're going to do regenerative medicine, don't forget to take some courses on just 5% dextrose. It's great. And your most important course that you should ever take for doing any type of injections is anatomy. Again, one of those courses that I wasn't really excited about when I was going through school, but if you just visualize what's in this area, where's this needle going, where does it need to go, and you just understand the anatomy, you can get there. And I have a lot of colleagues now that are doing ultrasounds, watching the needle go in, knowing exactly where it's at, and they get good results, definitely. But I've been getting good results just by knowing my anatomy and just visualizing where that needle needs to go. I mean, I'm always debating with myself, do I want to get into doing the imaging with the injections? And right now I'm leaning towards not doing it just because it's a whole aspect. So anyways, anatomy, it's very important. So sugar is like my number one injection thing. So I use 5% all the way up to 25%. And again, it's just sugar water. But so the 5% dextrose, so that's neuroprolo, and then sometimes people are like, that's not enough, and then I'll add like procaine. So procane's like most mild numbing solution, and I'll do that as trigger points for my PI cases. Or any type of case, I'll do just right into them. So both procaine and D5, it helps to reset them, and you'll see this progression. And as I do it for these acute injuries, it's like they just, they will say, it's because of the shots, I do feel better. And my biggest issue with shots is pain, right? But the pain I'm causing people. So, so that's a whole other aspect. How do we get people, because if I can make it painless, if I can make it so it's a massage, they feel like that with it, my practice would be, I would be 4 weeks out, people wanting to come in. But, a lot of it's, people are afraid of shots. So there's techniques I've learned over time on what to do, how to make it so it doesn't hurt as much. If you're pushing really hard, you're basically distracting as that needle goes in. Sometimes wiggle it in, using the different needle sizes. So
breathing techniques.
Oh gosh, I have to teach people how to breathe. People will just sit there, just hold their breath and tighten up. It's like, oh my gosh, So of course they're in pain, and so you have to teach them, how to do yoga breathing and just work through that. And I turn on some ocean sounds. I'm considering doing like nitric oxide and knock them out a little bit, do some laughing gas. So gotta look into that. I haven't heard of any of my other colleagues doing that, so I don't know. I'm pretty sure I can, but that's something I'm thinking about researching.
That's not a little excessive.
There are some people that really, no, there are people I have to, there are some people I have to give benzodiazepines to one dose. They'll come in, they'll be driven in, and just because they have such a fear of shots.
Like doing like biofeedback after like 5 minutes of brain training.
I had this one patient, she came in, she's like, I know this is gonna help me, it's gonna help me. But she was just like hyperventilating through the whole thing. I was doing all these shots on her, and it was painful for me. And then, the second time she came in, she said, okay, doc, hold on. I learned this technique. And she went through this whole mental exercise, this, breathing technique, and she just sat there and focused and meditated for about 10 minutes. And it was like a different person. It was amazing. So, yeah. So, biofeedback, all those are great. Sometimes just giving a pill is easy. It's only one pill, So anyways, that's definitely a struggle. So, so from trigger points, the neuroprolo, and then as you increase the strength of that dextrose solution, then you're creating more of this reaction in the body, right? So that's where we're starting to call it prolotherapy. Traditional prolotherapy is at least 15% dextrose, up to 25%. And I tell my patients what I'm going to do is put an irritant right there, right in that spot that we want the body to heal. And sometimes I look at it as just reinitiating that healing inflammatory response because it never fully did what it was supposed to do. Sometimes I'll do it because there's a small tear in a ligament or a tendon. We'll do the shots in there. That usually I do dextrose 25 mostly. Sometimes it'll be a little bit less, but someplace in there, and it'll create that strong inflammation. Usually lasts about 12, 24 hours, and it's amazing, right? Sugar, just using sugar, it's amazing. Where usually they'll be in pain for about 12 to 24 hours. As that starts to drop down, they'll start noticing, oh yeah, it doesn't hurt as much. My tendon cell though, it's feeling better. I had this one kid, oh my goodness, he was 13 years old, hockey player, and has fallen many times on his wrist. They were hurting him all the time. And his mom talked him in to coming in to do some prolotherapy shots. And so I told him it's going to hurt for about 12 to 24 hours after we do these shots. So I did the shots on him, and then I saw him a week later, and she told me the story that it started hurting him. And he started blaming his mom. He's like, Mom, I can't believe you made me go there and get these shots. Now I can't ever play hockey again because my wrist they're in pain constantly now. But sure enough, after 24 hours, things started dropping down. And it's like, that was it. And then he sent in his cousin, who was like 18 years old, and she was like some softball player, and had amazing results. And a lot of that's just age, right? The younger you are, the better prolotherapy works.
He's playing for ASU now. He's a top player.
Really? Cool. I had something to do with that.
That's the fun part.
Yeah. So, one problem as we get older, the prolotherapy, that innate response of the body just starts to slow down. It's not strong. Then that's when we start using other types of injections like PRP or amnio, amniotic fluid. So PRP, we just take blood out, centrifuge it, and then harvest out the platelet-rich proteins from it, inject that back in. So I usually, I pretty much always use that if I have some osteoarthritis or chondromalacia going on in the patella area. So we're already missing some of that cartilage, right? So we want that body to start to re-heal. And that person's going to be older anyways. So I've had really good success with just using PRP in those areas. Sometimes people need a little bit more. Usually I'll do that PRP for a while, and it's like you just hit this plateau where it's just not getting any better, and then that's when we'll do an amnio injection. And those can be more expensive, right? And so that's the most I do. And just so you know, the amniotic fluid is taken from a baby that's born C-section, and then they harvest out the amniotic fluid from that. And so it's just rich with stem cells and protein factors in it. And there's other treatments out there. I know that Dr. Grofrock, he harvests the stem cells right out of you, or fat cells, or bone marrow. So there's always those. The amnio is just a simpler procedure. You're getting it from a donor. What else? I don't know what else to say.
So basically, we wanted to share with you today the topic of how we work together, and then specifically how Dr. Todd does the injections. We have so many other topics we can talk about.
I didn't talk about ozone. I didn't talk about ozone. Let me talk about ozone real quick. Started doing ozone about six years ago, and I can't imagine my practice without it. So I know it's controversial. In fact, I know there's some people in college, it's like, oh, it's horrible. But I've had amazing results with it. I think it's great. I use it mainly for interarticular injections. I do some intermuscular. Whenever I do PRP, I'll do ozone along with it. It's a great sterilizer. It's a great, increases microcirculation, increases mitochondrial function. Ozone is basically 3 oxygen molecules, right? Oxygen is happy with, as a pair, and you run through the machine, and it turns into 3, and they're not as happy. So then they want to break apart and make all this oxidation, right? So it's an interesting therapy. Highly encourage you to look at it. I use it also for disc treatments. So in our office, pretty much 2 things we know that we can help disc patients with. So the disc is protruding, bulged, pinching on that nerve. We can do decompression. Decompression's been around a long time. We have a decompression machine. We hook them up to it, and it creates that slow, steady pull, and helps that disc to start to move back in, away from the nerves. But usually what I do right before that is I'll inject ozone into the rector spinae muscles corresponding with that disc. And because it's a gas, it'll just kind of work its way down to where that disc area is. And so that's just been another thing we've added, and it's worked well. That particular procedure has been around since the early 80s. It's called Discosin, from this Italian doctor who came up with it. And so we've just kind of put it together with decompression. So we're happy with that procedure.
The ozone for
So I use ozone, rectal, vaginally, nasally, tonsils, IV. There's a procedure where you take your blood out, put it in with the blood, and it drips down, goes through UV light back into the person. So I do a lot of those, mainly for colds and flus. People just have a hard time getting over them, and consistently see people turn the corner whenever they get that type of IV.
I always do.
Yeah.
Do you see faster results with that than you would if someone was came in for like B12 shot or the whole, what do you call it?
Myers cocktail.
Yeah. So you see faster results with the ozone therapy for people who have a cold or sickness or sinus versus?
Yeah, just my personal experience with Myers cocktails, it's the other IV I do. Right? Just Myers cocktail and then my ozone ultraviolet. That's it. Myers cocktail, sometimes I'll do it right after the ozone, so sometimes it's used that way. If it's used by itself, it's usually more for adrenal issues or just feeling tired or fatigued or just needing some type of boost. It seems like it works well in that capacity. Or if someone has had a cold or flu and they're getting better, but they just need help with the recovery process. Seems well for them. But it's not. I don't think of it for helping with recovery from the cold or flu. Just my experience. Any other questions? Yes.
About the polo and the perineural shots, what is the difference between it being 5% dextrose and like the liver pain immediately versus like the 25% that's also more?
So,
What's the mechanism?
5% dextrose is isotonic. So there's even IV bags, 5% dextrose. You can just go right into your blood. It's not going to hurt it, right? Because it's similar consistency. So if you do an injection with that, you're not going to feel it. It's not going to create that reaction. When you start going above 5%, then the body's going to create this inflammatory response. And so that's the difference between the neuroprolo and moving into prolotherapy, where you're getting that response. Neuroprolo, Dr. Lippincott, he has a lot of seminars out there. You can learn his techniques. And he was a prolo doctor, and then he switched over and started doing the 5% solution. And but he'll talk about in his seminars how it helps to actually heal the nerves. And you use really small needles, and you're mainly thinking about, is this a nerve injury? And that's been my experience. It seems like that's what's helping. What helps with.
Any other questions? I have a really bad question. I know we have to wrap up, but I have a prior client of mine who has Guillain-Barré, which is all non-degeneration. She has it.